Hi everybody, this is Dr. Jarvik, and today we are going to be talking about acid-base imbalances. So with acid-base imbalance, the acidity or alkalinity of a solution hinges on the concentration of our hydrogen ions. So an elevation in hydrogen ions results in acidity, while if there's a lower hydrogen ions, it leads to alkalinity. Typically, we quantify hydrogen concentration through a negative logarithm denoted as pH. So that's what we'll be talking about, pH. So this logarithmic scale implies that lower pH values correspond to higher pH concentrations. So typically, the pH scale scans from 1 to 14, with pH of 7 being neutral. However, in the blood, we're looking for a normal pH range of 3.5 to 4.5. And so anything below a 7.35 is medically considered acidosis, while anything above 7.45 is considered medical alkalosis. So the body has several ways that it works to try to keep acid-base balance, and buffers are the first line of defense against changes in free hydrogen ion levels. So all body fluids contain buffers, and the major buffer in ECF is our carbonic acid bicarbonate systems. So it acts chemically to change strong acids to weak acids or bind acids to neutralize them. And then the respiratory and renal system have to be functioning properly in order for the buffers to work. And it's not necessary for you to memorize the different buffers, but some of the common ones are phosphate, proteins, albumin, and globulins. Now, our respiratory system is considered the second line of defense. And as we kind of talked about this previously, hyperventilation, so breathing faster, is going to lead us to eliminate more CO2 or carbon dioxide. And so if we are breathing out more CO2, we're going to have a decrease of CO2 in our blood. Likewise, hypoventilation, that decreased respirations, is going to lead to CO2 retention. And our normal PA CO2, and you'll often just see me write CO2 just for simplicity, a time frame, normal is 35 to 45. Now, our kidneys are responsible for the third line of defense. So they actually take about 24 to 48 hours to respond, but when they do respond, they have a really strong ability to regulate the acid-base balance. And so kidneys help to move the bicarbonate. It conserves bicarbonate and excretes some acid. And there's three main mechanisms for acid secretion. So it can be secreting minimal amounts of free hydrogen into the renal tubule, or formation of ammonium, which is NH4, by combining the hydrogen ions with ammonia. So NH3 plus a hydrogen equals NH4. And then the other way is through excretion of weak acids. And normal bicarb, which is our HCO3, is 22 to 26. And of course, these are numbers that you're going to need to memorize for this content. Now, what is the first line of defense in the acid-base balance? We will review this in class. All right, so moving on to arterial blood gases. So some RNs are able to draw ABGs in the ER or ICU settings, and where I worked on the cardiovascular step-down unit, because we had a lot of cardiac patients, the open heart patients, or thoracotomy patients, we had a lot of patients who had the potential for really declining, and so we were specially trained to draw ABGs on that unit, and that's pretty uncommon for a telemetry unit. So in most organizations, the respiratory therapist can draw the ABGs. And so you need to do a modified Allen test before drawing ABGs. And you can see here that they are squeezing both the ulnar and radial arteries. And you would typically have the patient open their hand up while you're squeezing it 5 times, and then while it's open, you're going to release that ulnar artery. And this is going to be checking to make sure that if we screw up that radial artery, are they going to lose their hand? So a positive modified Allen's test is when it pinks up the way it's supposed to, and a negative modified Allen's test is when it does not. So the reason we do acid-base balance ABGs is that we're looking at some information. Number one, it tells us the acid-base status of the patient. Based on what's the numbers show, will tell us the underlying cause of the imbalance, and this will make more sense as we go through this more. It also tells us the body's ability to regulate the pH and the overall oxygenation status of the patient. So again, normal ABG values, these are something you need to memorize. pH 7.35 to 7.45, and this is for arterial blood. We will not be testing on venous blood in this course. PaCO2 of 35 to 45. If you notice, one of the ways that helps me to remember this is that, I've got 7.35 to 7.45, and this is 35 to 45. So that may help you also. And then our bicarb, HCO3, 22 to 26. And PaO2, 80 to 100. We'll talk more about this. And then, of course, you already know the SaO2 is 95%. You don't need to know these to determine acid or alkalosis, but it does tell you the status of your patient. So it's really important. So the way we actually interpret ABGs is we're going to look at each of the values. You always look at the PaO2 and O2 saturation first, and that's so that we know if we need to put somebody on oxygen right away. We'll focus this next week. Then you're going to look at your pH. That's going to tell you if something is acidotic or alkalotic. Then you're going to use Rome to determine respiratory or metabolic, and I'm going to discuss that more on the next slide. And then you determine if the patient is compensating. So we are not going to read partially compensated or uncompensated or fully, actually, we're not going to read partially compensated or fully compensated ABGs. That'll be in your further ones. But you will assess the PaO2 and oxygen saturation, determine again if we need to do that oxygenation. All right, so the Rome mnemonic. This is one of the easiest ways to figure out acid-base balance. So respiratory, our component that tells us it's respiratory is our PaCO2. So this is the number we're looking for. Our metabolic is our bicarb. And so it's always, if my bicarb is off, then it's always bicarb and a metabolic issue. If my PaCO2 is off, then it's a respiratory issue. So the Rome method is, if I have an increased pH, I'll have a decreased PaCO2. And so you'll notice that this is respiratory opposite. Same thing with acidosis. If I have a decreased pH and increased PaCO2, this one is going to be respiratory acidosis. And with metabolic, it's going to be equal. So if my acidosis is going down, my bicarb will also be going down. And then bicarb alkalosis, they will also be going up and up. So this will make more sense when we do some practice ones in class. So actually, I'm going to go ahead and do one practice here, and then we'll save the rest for class. So looking at this, look at my pH, and my pH is 7.12, and normal is 7.35 to 7.45. So for this, I'm going to draw my arrow down. So my pH, and if you're looking at this, I've already given you the answer here. It is acidosis, right? So our pH is our last name. Now we look at the PaCO2, and this is normal, 35 to 45, so totally normal. Look at our PaO2, it's 70. Houston, we have a problem, that's too low. We would put oxygen on this patient. And then we look at our bicarb, and it's 15, and so this is also low. So remember, our metabolic equal, they're both going the same way, and it is a bicarb issue, we now know that this is metabolic acidosis. So we'll save the rest of these for in-class practice, but I just wanted to give you a little bit of an idea of how to do this. Now we're going to look at just acidosis in general. So again, acidosis is when that pH is below 7.35, and that means that there are excess hydrogen ions. Remember how I talked about with our electrolytes that potassium is important to know with acidosis? So potassium can move from the intracellular to the extracellular, which is why we are going to see hyperkalemia in acidosis. So with respiratory acidosis, this may be caused by excess buildup of carbonic acid, just a fancy way of saying our CO2, and metabolic acidosis may be caused by a base deficit or bicarb. Acid besides carbonic accumulates in the body like a ketoacidosis or a lactic acidosis, and we'll talk about some of those causes there. Or the kidneys lose the ability to reabsorb bicarbonate and excrete hydrogen, or the loss of bicarbonate with severe diarrhea. So with acidosis, there are some similar signs and symptoms. So we know our assessment, recognizing cues, the signs and symptoms. So whether it's respiratory or metabolic, notice that we have some of that lethargy, some of that confusion. Both of them have headaches, coma potentially. So a lot of these are the similar for neurological. So whether we're talking about acidosis, cardiovascular, both of them have decreased BPs. Both of them have risks for dysrhythmias because of that hyperkalemia, and both are going to have that warm, flushed skin. Now with respiratory acidosis, because it's our breathing, there's no significant findings, but with metabolic, there can be nausea, vomiting, diarrhea, abdominal pain, and some of these could actually be the causes for it. Neuromuscular, with respiratory, we have the risk for seizures, and neuromuscular and metabolic, we have muscle weakness. And then for respiratory, we're going to have hypoventilation, and that's what's actually causing this respiratory acidosis, right? We're breathing shallow, which is causing us to retain that CO2. So with that, we can have a hypoxia, shortness of breath. They could have rapid, shallow breaths, but the bottom line is that they are going to not be blowing off that CO2. So the lungs are what's actually affected, and they can't be the ones to compensate. It would have to be the kidneys that compensate for the opposite thing. Now looking at our metabolic, the way that for metabolic, our kidneys are going to be the one that actually kick in to help with that fixing this metabolic issue. So we're going to see deep, rapid respirations. They're already acidotic, so if we blow off and increase our respirations, we're going to blow off that CO2. And CO2 is an acid. It's a very potent acid. So these Kussmaul respirations are compensation. And then they may have that fruity acetone breath, depending on what their cause is. So again, for our respiratory acidosis, we're going to have a pH less than 7.35. Our PaCO2 is going to be above 45. And remember with that, that's where we have our opposite, right? So this is up and one's down and one is up. And the bicarbonate is going to be normal. And then our potassium is elevated with acidosis. And one of the things that we can do is to do a chest x-ray to help diagnose the problems because it's a respiratory issue. And then we're going to monitor for cardiac dysrhythmias. So we're going to be making sure that there aren't any things going on with that. Now with our metabolic acidosis, we are going to be seeing that pH is again going to be less than that 7.35, but our bicarb, also known as our HCO3, is going to be below that 22. So again, notice that they're going in the same way. So metabolic equal. Our PaCO2 is going to be normal. Potassium is going to be high again because this is acidosis. Doesn't matter if it's respiratory or metabolic. We still have the risk for cardiac dysrhythmias. We're going to see an increased anion gap, and I'll talk about that later on. And if they have DKA, we'll see high glucose levels. And increased lactic acid level is going to be there for septic shock, cardiac arrest, or if it's secondary to strenuous exercise. So we can assess an anion gap in our chemistries, the renal panel. So we can just draw blood venously and we'll be able to see an anion gap. And so it's looking at the cations and anions. And so it's going to measure the difference or gap between the negatively charged and positively charged electrolytes in the blood. And so, for example, the anion gap can be determined by looking at a Chem7 renal comprehensive metabolic panel, depending on what you're calling it. And it's going to be the sodium plus the potassium, and those would be in parentheses, minus the bicarb plus the chloride. So your positively charged and your negatively charged chemistry. And so this is one way that you can check and see what is going on even before we do an ABG. It can help to identify the reasons for the acidosis. And so a normal anion gap is between 8 to 12. And the level increases with acid gain, but remains normal with bicarbonate loss. And there's that formula that I was talking about here. That's sodium plus potassium minus the bicarb plus the chloride. All right, so acidosis, analyzing cues. So again, this is going to be the things that could be causing it. So analyzing cues is another way of potential causes. So some of the things for respiratory acidosis: COPD, chronic obstructive pulmonary disease, asthma, sedative overdose, alcohol overuse, barbiturates, which barbiturates slow us down, severe pneumonia, atelectasis or respiratory muscle weakness, spinal cord injury above the diaphragm, airway obstruction, hypoventilation. And you notice up here, all of these things are causing hypoventilation, respiratory depression, pulmonary edema, which is actually fluid in the alveoli, chest wall trauma, or CNS trauma that affects the respiratory center. Now, metabolic acidosis can be caused from diabetic ketoacidosis, also known as DKA, diarrhea, starvation, renal failure, GI fistulas, shock, or poisoning, specifically aspirin, which is known as acetylsalicylic acid. And so it actually has acid right in the name. So if we take too much aspirin, it's going to cause a metabolic acidosis. So what are we going to do? What are our interventions going to be for somebody with acidosis? Respiratory acidosis, we're going to closely monitor those vital signs, cardiac monitoring because of that hyperkalemia, monitoring the level of consciousness, the work of breathing, intake and output, our electrolyte levels, and repeat ABGs as appropriate. Remember, ABGs can cause damage to our hand, and so we don't want to do that if it's not necessary. Bronchodilators or rescue inhalers such as albuterol will help to open up the airways. Supplemental oxygen may be appropriate if our PaO2 is less than that 80 or SpO2 is less than that 95. They may actually need to be intubated with mechanical ventilation or use CPAP or BiPAP. And CPAP is continuous positive airway pressure, and BiPAP is which is a bi-level positive airway pressure. And so BiPAP is especially really good with somebody with high CO2. It helps to blow off that CO2. If somebody with respiratory acidosis, maybe they have pneumonia, we're going to give antibiotics to treat that infection. If they have a lot of secretions, we may need to suction them, have them use their incentive spirometer and cough and deep breathe, possibly hydration to get rid of some of that mucus if they have really thick, tenacious secretions. If they have an airway obstruction, obviously we need to remove that. we're going to need to correct the hyperkalemia. And if they have an overdose, we're going to need to reverse the overdose. Now with metabolic acidosis, a lot of those things that we're monitoring are the same. So we're still going to be monitoring the vital signs because we're worried about that blood pressure. Cardiac monitoring because of that hyperkalemia. With this, it could be glucose level if it's DKA. Level of consciousness is still important. We may need to support breathing if they are having a lot of those Kussmaul respirations. If they're working really hard at breathing, they're eventually going to fatigue and may stop breathing. Intake and output, monitoring our electrolyte levels, and repeating ABGs as appropriate. So fluids and insulin are going to be important to treat DKA, and we'll talk about this more later on this semester. Rehydration and antidiarrheals to treat prolonged diarrhea. We may need to actually administer sodium bicarbonate, and that can be given PO or IV. Correct the hyperkalemia. They may actually need dialysis if they have this from renal failure. And again, if it is shock, sepsis, that type of thing, we may need to give antibiotics to treat that underlying infection. So now let's talk about alkalosis. So basic pathophysiology, we're going to have an excess base, especially that bicarbonates. Remember, that's that HCO3. A decrease in free hydrogen ion level in the blood, and that pH level of 1.45. So it's going to be elevated. Now with respiratory alkalosis, we're going to have that ABG with an elevated pH with the low CO2. So again, see how that is respiratory opposite. Versus metabolic alkalosis, we're going to have an increase in base, which, and it's going to have an, so we're going to have, again, that increase in our pH, and we will have increase in our bicarb. So remember, this is our alkalosis, it's metabolic is going to be equal. So they're going in the same direction. So alkalosis assessment. Again, you're going to see a lot of similar signs and symptoms. So they're both going to have potentially confusion, headache, dizziness or lightheadedness here versus some irritability. Cardiovascular with respiratory tachycardia, can have that cardiac dysrhythmias, again, because of that hypokalemia. So here, cardiovascular, we can see that hypokalemia and metabolic. Gastrointestinal, we can have nausea, vomiting, diarrhea, epigastric pain, or in metabolic, we can have the nausea, vomiting, and anorexia. Remember, anorexia is just a decrease in appetite, not like anorexia nervosa with the mental health issue with body dysmorphia. Neuromuscular, we can see tetany, numbness and tingling of extremities. And of course, hopefully that makes you think of hypocalcemia. We can also see hyperreflexia and seizures. Now with metabolic, we can also see tetany, tremors, tingling in the extremities, muscle cramps, and seizures. From a respiratory standpoint, with alkalosis, respiratory alkalosis, we are going to have hyperventilation. And so they are breathing fast, they're blowing off that CO2. Versus with metabolic, they are going to have hypoventilation because they are trying to compensate for that alkalinity. And so if we retain that CO2, we are going to have, by breathing, that's going to help make that difference between that acid-base imbalance. So again, respiratory alkalosis, we're going to have that pH that is above with that PaCO2 that is down. Bicarbonate will be normal. We see hypokalemia with alkalosis. Serum calcium is low. And cardiac dysrhythmias because of that issue with our potassium. Now with metabolic alkalosis, Our pH, again, because it's alkalosis, is going to be elevated, but our bicarb, or HCO3, is going to be elevated. And remember that metabolic means equal, so that the arrows are going in the same way. Our PaCO2 would be normal. Again, with all alkalosis, we're going to have that hypokalemia and that hypocalcemia. And because of that potassium, we have that risk for our dysrhythmias. So, analyzing cues, also known as potential causes. So, with respiratory alkalosis, anything that can cause hyperventilation. So, hypoxia, anxiety, fear, labor, panic, exercise, fever, those can all cause hyperventilation. It can also be from stimulated in the respiratory center in the brain, liver failure, or mechanical hyperventilation. So when they are intubated, the respiratory rate is too elevated. The things that can cause metabolic alkalosis: vomiting, prolonged NG suctioning, diuretic therapy. And so when you think of diuretic therapy, hydrogen ions are being lost, which we know our hydrogen is our big thing that is what determines our pH. Or it could be excess intake of sodium bicarbonate. So alkalosis interventions. With respiratory alkalosis, we're going to closely monitor vital signs, cardiac monitoring, level of consciousness, the work of breathing, intake and output, electrolyte levels, and repeat ABGs as appropriate. Because it's respiratory, give oxygen as needed. And with somebody with respiratory alkalosis, specifically if they're anxiety or panic, we're going to have them breathe into a paper bag or cupped hands, because that's going to help them rebreathe that CO2. If it's from mechanical ventilation, we'll adjust the breath per minute. If they're having anxiety, if we can't get them to calm down, we may give a sedative such as a benzodiazepine. Always whenever you have somebody who is anxious or panic, we want to get them to a calm environment. With alkalosis, we're going to watch for seizure precautions, and we would want to correct that hypokalemia and hypocalcemia. So metabolic alkalosis, again, we're going to monitor all those things we've already talked about: vital signs, cardiac, level of consciousness, work of breathing, our eyes and nose, electrolyte levels, and repeat ABGs as appropriate. Oxygen as needed. Stop diuretics if they're the cause. Stop NG suctioning if that's the cause. If they're having nausea and vomiting, we might administer an antiemetic such as ondansetron or promethazine. We may need to administer ammonium chloride in severe cases. And we want to teach patients not to use baking soda for GI upset. It's really cheap, and so some patients will actually just take baking soda, and they could cause themselves to go into metabolic alkalosis. And then seizure precautions. And, of course, correct our hypokalemia and hypocalcemia. So I hope this voiceover was helpful. It is one of those things that you just got to get in and practice, and we will work on this together in class.